right, guys, Dr. Ash here. Today we're going to talk about contraceptives and sexually transmitted infections. This is actually just one of two videos in regards to kind of women's health slash pregnancy and prevention of pregnancy, those types of things. So the first talk for today is going to be specifically contraceptives and sexually transmitted infections. So let's talk about contraceptives at first. So from the nurse's perspective, from a nursing school perspective, one of the things that we want you to be able to understand is how to assess the readiness and kind of where that patient is in regards to contraceptives, and then of course education on the different contraceptives and best practices for those contraceptives. So when a female comes into the clinic and they're asking you about contraceptives, this is kind of the things that you want to focus on. So number one, an allergy to latex, because the male barrier condom is kind of the first thing that people think about, and that is typically latex. There are some latex-free options, but definitely want to assess for a latex allergy because we want to avoid things that may contain latex. Also, if they want to be independent of their partner or dependent on their partner. And basically what that means is if I'm reliant on my partner to control birth and pregnancy, then that would be the male barrier condom, or a vasectomy, which is more of a sterile procedure that can be reversed, but we'll talk about that in a minute. Or do I want to be in control of it? So do I want to be on a birth control pill? Does the female want an intrauterine device, barrier device, spermicides? There's all different kinds, but part of what we would do is assess where she's at and kind of what her plan is in regards to birth control. And then future plans of pregnancy. Does she want to be pregnant 2 years, 5 years, 10 years from now? That can also depend on what kind of birth control that we recommend. Does she have any preferences? So one of the things that's beautiful about the society that we live in is that we oftentimes, our patients come in with a baseline working knowledge of things already. And so 9 times out of 10, they've probably done their own research. And so you want to ask them, do you have any preferences? Do you want a hormonal or a non-hormonal, or basically what are your plans and what you're looking for? And then of course, the reliability of the devices. Not only do we need to assess whether she knows the reliability of the devices, but also what kind of reliability is she looking for? Does she want a high chance of not getting pregnant, or is she kind of like, if it happens, it happens. If it doesn't, it doesn't. So all things that we want to assess. So let's talk about the different contraceptives. I've broken it down into hormonal and non-hormonal. We'll talk about non-hormonal first. This means there are no hormones involved, no medications involved, and this is simply just some sort of barrier to prevent the sperm from getting into the uterus. And so that's kind of our first one that we're going to talk about. There are a couple of other devices that the sperm can actually enter into the uterus, but there's some sort of reaction that keeps it from impregnating or fertilizing an egg. And so the barrier method, most people think of condom, but really diaphragm and cervical cap, those fall into the same category, preventing sperm from entering the uterus. So the thing with all three of these is they have to be used correctly each time. So there's no point, well, there is a point in keeping it, right? Because you do have some protection to a certain level, but they also have a failure rate if they're not used correctly. And so again, it's one of those things that if you don't use it the right way, then the chances of being pregnant become much, much higher. And then the male latex condom, best way to prevent STIs, because there's no exchange of body fluids. There's no exposure to big mucous membranes that are vascular, such as the vagina. So that is the best way to prevent an STI. Of course, the diaphragm is a small, flexible silicone cup. It covers the cervix. There is no protection or barrier against the vaginal mucus wall and sperm getting in there or any other body fluids. And so there is a risk that comes with STIs with diaphragms and cervical caps. Again, must be used correctly. It is best when it's used in addition to spermicide. So spermicide we're actually going to talk about on the next slide, but when you combine the diaphragm and spermicide, it's like better coverage if that's the choice that you want to make. And then the other thing with the diaphragm, it's best to be left in place for at least 6 hours after sex. So there are remnants of sperm that can kind of hang around in the vagina for up to 6 hours. And those can find their way to the uterus if you were to take that cervical or that diaphragm out too soon. The other thing I want to say about the diaphragm with spermicide it would be the best choice for smokers. So as we get to the hormonal birth controls, which we'll talk about in just a minute, they come with a high risk of things like strokes and blood clots and heart attacks. But it's even worse when that patient is a smoker. So for our smoking patients, we definitely want to do a non-hormonal choice, the best being the diaphragm with the spermicide. Next is the cervical cap. Basically just the exact same thing as the diaphragm, except it's a little bit smaller. And it can stay in place up to 48 hours after sex. I don't know how I feel about that, but again, it's your own personal choice or your patient's personal choice of what they would prefer. Next, we'll go into the spermicides. This is actually a cream or an ointment or a suppository in some cases that are actually placed in the vagina before sexual contact. By themselves, they have a 21% failure rate. So not exactly the best choice alone. That's why I say when used in conjunction with the diaphragm, they actually become probably around 90% effective. So that's kind of nice. We have the Paragard, which is a non-hormonal IUD. It's actually a copper IUD, and it can prevent pregnancy for up to 12 years. So this is really a long-term fix to not wanting to be pregnant. So if you have, early 20s and you're not planning on it for a really long time, or you're past the time you want to have babies, and you want to prevent it from getting pregnant in your 30s and 40s, this might be a choice as well. Basically what happens, there's no hormones in it. So how the heck does a copper IUD work? Well, it's placed inside the cervix, intrauterine device. It's placed inside the cervix. And what happens is that copper creates an inflammatory reaction in the uterus, and it keeps the sperm from actually attaching to the wall, fertilizing the egg, and then the egg attaching to the wall of the uterus. So it's an inflammatory response. So you also have to keep that in mind. And then of course there's sterilization, and there's two forms of sterilization. There is the female, which is the bilateral tubal ligation or BTL, where they go in and they actually clip sections of the fallopian tubes off. And then there's a vasectomy where they go in and they clip the vas deferens. Both of these things are considered permanent and sterile. However, there are some situations where they can go in reverse, where they take off the clipped portions and they reconnect the tubes, either in the fallopian or the vas deferens. And sometimes it works, sometimes it doesn't, sometimes it's too much of a scar tissue. So that's why we call it permanent, because the reversal is not guaranteed. We'll move on to a couple of hormonal contraceptives, and these are probably the most common that people have heard about. At least from the female perspective. Again, the male barrier condom seems to be the most common, but hormonal contraceptives, birth control pill, it can have progesterone, it can have estrogen, it can have a combination of medications, it can be low dose, it can be moderate dose. There's 1,000 birth control pills if there's one, guys. Vaginal ring actually has some hormones in it to keep the cervix from being able to house a pregnancy. The IUD, the most common is the Mirena. There's also Skylar, and there's a couple of, it's Sky something, I forget what it is. But these actually go into the cervix again, but they also have a level of hormone release that prevents the uterus from being able to accept a pregnancy. There's the Nexplanon that usually gets implanted into the upper arm. Again, slow release of hormones. There's also the Depo shot. There's just tons. We could go on for hours here, but we're not going to. But the thing to remember is there's a high risk of problems when it comes to hormonal therapy. One, blood clots, especially in our smokers and those north of age 35. So anybody on long-term birth control and a smoker over the age of 35, it's kind of a perfect storm for a blood clot, if you will. Strokes, heart attacks, hypertension, tumors of the liver, gallbladder disease, lots of high risk things, which is why a lot of women are becoming empowered and getting away from the hormonal contraceptives. Very common side effects: tender breast, nausea, increased appetite, fluid retention, and weight gain. Those are just some very common side effects that you may see pop up on the test. Remember, my kind of theory on this is the NCLEX and nursing test, we usually don't do more than 3 or 4 common symptoms, 3 or 4 most common complications. So that's why I don't have a list that's all inclusive here. All right. from most effective to least effective. And then again, this is helpful for your patients. This is helpful for testing purposes, everything in between. So of course, the bilateral tubal ligation or vasectomy would be top because those are sterilization procedures. Next, we have oral contraceptives if they're taken the way they're supposed to, the male condom, the female condom, the rhythm method, which is around your cycle and timing, but you can be off by a couple of days and still get pregnant. So that's why it's kind of on the bottom of the least effective side. And then spermicide by itself, because remember that has a 21% failure rate. And one more thing that I want to say, and this is a segue into our STIs, is that sterilization does not protect against STIs. So even though you have sterilization, you're on oral contraceptives, cervical caps, diaphragms, those are nice, but they will not protect you against sexually transmitted infections. Good for pregnancy, not so good for STIs. A little bit about infertility. I'm not going to go there too much just because there's not a ton of content that comes on this, but just understand that infertility treatments can be very extensive. It can be years worth of therapy, and it can also be very expensive. Now, commonly women will go to alternative therapies when it comes to infertility, just because it does get so expensive, and it's simpler to buy an over-the-counter than to go through multiple rounds of testing. But to promote ovulation, certain over-the-counter things would be like black cohosh, progesterone, and plant estrogens. And in order to promote spermatogenesis in the male, so if it's a male issue with infertility, vitamins E and C, selenium, zinc, coenzyme 10, and ginseng have all been shown to improve sperm generation. Now, a couple of other things that I just want to remember, these are kind of like big ticket items, if you will. The semen analysis, if they're going to do a sperm count and motility on sperm, that specimen has to be delivered within 1 hour of obtaining it. So it has to be hot and ready is how I remember it. And then clomiphene or Clomid is actually a very common drug that we give to women to promote ovulation. So that's really all I'm going to say about infertility. Now on to sexually transmitted infections. So we have all different types. We've got tons, guys, and we can be here for hours, and that is not my intention, right? I like nice and fast videos. So just remember our two big types are going to be bacterial and viral. Bacterial, we treat with antibiotics. Viruses, we can't do a whole lot about. We can give antiviral therapy and some other things, but for the most part, they cannot be cured. And so our top three of each of these, bacteria would be gonorrhea, chlamydia, and syphilis, with chlamydia being the number one bacterial infection. And then viral would be herpes simplex virus or HSV, HIV, and HPV, which causes genital warts. So let's talk about each of these real fast. So our nurse's focus really should be risk factors. So it's good to know risk factors associated with STIs. We need to know the education from when our patient becomes infected, and then any potential complications that can happen as a result of having an STI. So that's your nurse perspective. So risk factors, it could be, well, that should be current and past, not past 0. So apparently I forgot to hit the shift key. But multiple sexual partners, either in the past or currently. We have a partner that has a known STI, of course. If we have a history of STIs ourselves, because that puts us at higher risk. If we're IV drug users, or if the partner is an IV drug user, any of the sexual contacts without a barrier method, or sexual activity while intoxicated, because intoxication drops our inhibition. So we tend not to make the best decisions when we're drunk or high. And then just a little word about age. It's been stigmatized that, just our young adults are prone to STIs. And while it's true, 15 to 24 is the most common age range, don't forget that our older populations are having sex too. And our older people are prone to STIs as well. So mandatory reporting. There are several STIs that have to be reported to the Department of Health and Human Services, Public Health, the Health Department, whatever you want to call it. And here's your list: chlamydia, gonorrhea, syphilis, HIV, neonatal herpes, and the chancroid. So a couple of different ones that I would remember here. So common bacterial infections, chlamydia, again, number one bacterial infection, typically is asymptomatic or has some yellow or very clear thin discharge. Treatment would be azithromycin, and it's a one-time dose. Gonorrhea usually found concurrently with chlamydia, so it's the number 2 bacterial infection. There is profuse green discharge, commonly called the drip, and it's treated 2 ways. It is treated with an IM injection of ceftriaxone, also known as Rocephin, and a PO dose of azithromycin. And there's 2 reasons behind this. Number 1, I think it was back in 2010, the CDC noticed that gonorrhea is becoming very resistant. So we have a high resistance to antimicrobial or antibiotic therapy. So that's why we hit it with 2. And because it's commonly found with chlamydia, you might as well treat for everything. So what you'll notice is azithromycin is kind of a catch-all for a lot of different bacterial infections. Last thing we're going to talk about in bacterial is syphilis. Again, it is back on the rise. Syphilis used to be kind of hidden. You didn't really hear much about it, but now it is back. And the thing with syphilis is because it's a bacteria, it will continue to advance if left untreated. And this is going to be important because people can actually die of syphilis. And so primarily you're going to see that chancre or ulcer pop up in about 3 to 6 weeks after exposure. Secondary will turn into a body rash. Early late means you're asymptomatic, and that could be through the duration of your life. And then there's tertiary, which is advanced syphilis, also neurosyphilis. The patient begins to have dementia symptoms, coordination issues. This eventually is what would kill them. And the most common treatment is penicillin. And so when it comes to penicillin, remember that's one of the top allergies in the United States. And so if we're treating a patient for syphilis, one of the first things we would ask is, are you allergic to penicillin? And that would give us an indication of whether we use penicillin, obviously not if they said yes, or doxycycline, which is our backup antibiotic, should it be needed. For our viruses, we have herpes simplex virus, HSV. I'm not going to go into the difference between 1 and 2 because 1 used to be oral and 1 used to be genital, but we are finding them everywhere. Okay, oral sex does not prevent the transmission of STIs. And so we are finding genital herpes come back positive on lip ulcers. So it can literally be anywhere. You will, or you may have an initial outbreak of blisters or lesions, very painful. They're burning and tingling before they pop up. They're just not a nice sight to have. Or it can lay dormant for up to 20 years and you never have an outbreak. Or you can have an initial outbreak and then you can have recurrence of symptoms because things like stress or periods or other infections can actually cause herpes to flare back up again. Treatment can be acyclovir, that is an antiviral, and that again can be daily or during flare-ups only. Daily is called suppression therapy. So some people who have outbreaks very commonly, like every couple months out of the year, they would be a candidate for daily suppression therapy. Now, we're not going to go into HIV because HIV gets housed under kind of an immunity, even though it's sexually transmitted. It's more in line with an immunodeficiency or an immune kind of concept. So we're going to go right into genital warts, which is also called chlamydia acuminata, if you want to be fancy, and it's commonly caused by HPV or human papillomavirus, which a lot of us are very familiar with. You've seen the commercials about Gardasil. So the primary prevention strategy is actually to administer the vaccine. And really the vaccination schedule is not all that important. Just know that that high risk group factor, that age 15 to 24, they're going to end up getting 3 doses of the Gardasil for the better protection, if you will. So these are actually papillary growths. They're usually white or very flesh colored. So initially they're kind of hard to see, but they will eventually enlarge into a very cauliflower-like mass, clusters, if you will, that become very evident and very painful. And so the important thing to understand is there are topical treatments and then there's cryoablation, which cryoablation is just freezing them off. But the topicals are also a form of cryo. It's just an ointment that you put on that they eventually lose circulation. They die, they fall off on their own. The 2 most common are the podophyllotoxin and the podophilium. If you want like a quick reference, I would look for that PODO because most of those common cryodestructive therapies, which is what this is called, or topical cryotherapies, start with that PODO. So just kind of be on the lookout for that. A couple of complications that I want to talk about, and then we'll wrap up here. So pelvic inflammatory disease, a very common acute condition that can cause inflammation of the uterus and fallopian tubes. And that's because oftentimes that discharge, instead of coming out of the vagina, actually crawls up into the cervix, attacks the uterus and the fallopian tubes. And then the most common thing that happens in addition to pelvic inflammatory disease is ectopic pregnancies. Because of that inflammation, we get pockets inside of our fallopian tubes that can very easily catch, if you will, an ovum that is fertilized, and then it turns into an ectopic pregnancy. Cancer, very common cervical cancer and cancer of the other reproductive organs. This is after repeated exposure to organisms, or HPV actually puts a higher risk for cervical cancer. Infertility, because of scarring of the fallopian tubes, and of course the ectopic pregnancy that may rupture, which ends up being a medical emergency, often seen by abdominal pain, pain that radiates up into the shoulder, very severe pain in the lower abdomen that moves up, is a potential sign of ectopic pregnancy. And then of course, signs of shock would give you an indication that it could be a ruptured ectopic pregnancy. And then perinatal infections. And all I mean by that is that some of these infections can actually be passed on to the fetus while it's growing inside the uterus, or it can actually be a newborn, a neonate born over the vagina. They get exposure to those fluids in the eyes and the ears and the mouth and the nose. And then next thing you know, we have a cerebral infection or a brain infection. So just again, very quick, that is all I have for you today. And I will see you in the next episode.